Well, welcome everybody. A few more people will be coming in, but just for some preliminaries, I'm Dan Polsky, uh, Director of the Hopkins Business of Health Initiative, and we host a regular series called Conversations on the Business of Health. And I'd like to welcome you all to this month's conversation, Procurement in the United States, Navigating Challenges and Shaping the Future. Our distinguished professor here at Johns Hopkins Carey Business School, Mario Masis, put this session together and is our moderator for today. And I'm going to turn the proceedings over to Mario.
That's great. Thank you very much, Dan. And good afternoon, everyone. And again, welcome to today's HBHI, or Hopkins Business of Health Initiative webinar. Your moderator, and I'm very, very excited about today's webinar. Members of the audience, thank you to all of you who are following us live, and also to those of you who are watching the recording on YouTube, or will be. You are absolutely welcome and encouraged throughout the discussion to ask questions. So just put them in the chat, which I will be monitoring, and we're going to leave 10 minutes at the end of today's webinar for those questions. Today, our expert panel will discuss and help us to understand the issues facing the procurement and allocation of human organs for transplantation in the United States. We will get into the key features of the system and challenges within it. And we're going to do that with a really extraordinary panel. I am really honored to introduce our panelists. We have Andrew Cameron, who is a professor of surgery, surgeon-in-chief, and the chief of the Division of Transplantation at Johns Hopkins University School of Medicine. Alexandra Glazer, who is CEO of New England Donor Services, a major organ procurement organization. Jean Moody Williams, who's the Deputy Center Director for the Center for Clinical Standards and Quality at CMS, the Centers for Medicare and Medicaid Services. John Snyder, Director of Transplant Epidemiology at Hennepin Healthcare Research Institute. And Dennis Wagner, who is Principal and Managing Director of Yes and Leadership and former Federal Executive with CMS and the Health Resources and Service Administration. Also for sort of full disclosure, Dennis and I were both members of a National Academies committee that produced a report back in 2022 with recommendations for improving the US organ procurement and allocation system. Now, let me quickly set the stage because before we get into the discussion. So the system is designed to match donated organs with patients in need of life-saving transplants. The system operates through a network of organ procurement organizations, or OPOs, across the country, which are responsible for identifying potential donors, obtaining consent, coordinating the process of organ recovery and transport. Once an organ is available, it's allocated to patients on a national waiting list, which is managed by the OPTN, or Organ Procurement and Transplantation Network. The network is overseen by the U.S. Department of Health and Human Services, and it prioritizes patients based on factors like medical urgency, compatibility, and other factors to ensure that organs go to those in greatest need or with the best match. Transplant centers, of course, play an essential role within the system. They're responsible for evaluating patients for transplant eligibility, listing them on the waiting list, and managing their care before and after the transplant. By working closely, of course, with OPOs and OPTN, transplant centers help to match organs to suitable recipients. Currently, there are more than 100,000 patients on the waiting list, and in last year, more than 46,000 transplants were performed across the country. Now, our panelists bring a lot of experience and expertise across medicine, law, healthcare policy, and leadership, and they have each contributed to advancing the organ procurement and transplantation field, to improve practices and driving meaningful policy reform. So let's begin. Now, because most discussions around this topic tend to focus on the negatives. And of course, we will address also, areas of concern. But I'd like to take, at least to start, I'd like to take a different approach. So for the first round of contributions from our panelists, I would like to invite each of you to take a couple of minutes to share your perspective on what is currently working well, what is currently functioning well from your point of view, within the US organ procurement and transplantation system. Then after this initial round, we will get into the system's challenges and areas of concern. And after that, we'll discuss possible solutions, reforms and ways to move forward and to improve. Let's begin. Dr. Cameron, Andrew, so from your point of view, what is working well? What are things that should make us proud of the system currently?
Thanks, Mario, and hello to everybody joining us this afternoon. So I am an active, clinically busy transplant surgeon. I participate in organ procurements and likewise in the transplants that result from them. The short answer to what is working well is there are 300 million Americans, 100 million consent to donation, and we are able to generate entirely through altruism, tens of thousands of life-saving organ transplants every year. That is, getting our country to agree on anything these days is a challenge, and 100 million Americans agree to that, which is wonderful. And I get calls, and we participate in the sharing of organs across states, across the country, and it is largely very efficient and very successful. And I have colleagues in other countries that I visit, Mexico, Turkey, Japan, and they are not as lucky as we are to have a highly sophisticated, developed, decades-old system for transparently, fairly, efficiently sharing life-saving organs. So I do think the discussion is very appropriately started by saying that, in general, the system does work well and does effectuate life-saving transplants. And, we probably should have, as a panelist, a person who's received a transplant could speak to the power of donation and of the system that facilitates that. Having said that, we're here to get better and serve the public even better, and there's appropriate discussion there as well. So again, thanks for including me.
That's great. Thank you so much. Alex, would you like to go next?
Yeah, absolutely. And I'm going to share a little bit of data to put to the comments that were just made, and hopefully everyone can see this. So, what's working well? Well, we've really have a system that's dynamic and improving, and that is working really well. We have a 98% increase over 10 years. And as just mentioned by my colleague, Andrew, this places us internationally in the benchmarks really at the top in terms of our deceased organ donation and transplantation system. To jump to my own experience, because I've been asked to present a little bit about what's working well here in New England. This is the OPO that I lead, which is MAOB, New England Donor Services. We're the third largest OPO in the US by activity. One of the things that's worked really well here is actually consolidation. This was our service area. It actually was 2 separate service areas in 2017. And consolidation of these service areas into a single OPO in 2017 worked really well. And this is the data that shows it worked well, both in terms of increasing performance and also increasing value by decreasing cost measured by reduction in the kidney fee. This was realized over 3 years, a $3 million savings. And that improvement and growth continued after the consolidation. So I think one of the things that's worked well for our OPO, and now we're seeing it in other areas of the country as well, is places where this kind of consolidation makes sense. There needs to be careful planning. The integration is complicated. It needs a lot of time in order to realize these kinds of results, but that the consolidation of resources and adequate staffing allows for innovative practices and best practices to be spread over larger geographic areas And as a result of that, some substantial increases can be realized. I'm just going to dive very quickly into one other thing that's working really well in our country right now, which is an increase in DCD donation that was identified in the National Academy of Science report as an area of growth. It's also been identified in multiple studies as an opportunity for the U.S., and that's working really well. Over the past number of years, there's been a substantial acceleration in growth in DCD.
Alex, I'm sorry, could you, for the members of our audience who might not be super familiar, could you explain what DCD?
Yes,
donor?
absolutely. So this
Thanks.
is donation that occurs after there's been a cessation of circulatory function. So typically in the past, and this is in now the very distant past, donation has primarily been a clinical pathway where the donor has been declared based on the absence of brain activity or brain death, as we understand that term in standard language, and so neurologic criteria. And instead, there's an opportunity for growth for organ donation when an individual doesn't meet brain death criteria, but a decision has been made that the ventilator is going to be removed. There's an expectation that the patient is going to pass away, and the recovery of organs for organ donation is still an opportunity after death has been declared in that circumstance. And that circumstance is donation after circulatory death, or DCD. And DCD has been a more robust practice in other areas of the world, Europe in particular, and identified as a growth opportunity here in the US. And in fact, as you can see in this data chart, there's been an enormous increase in DCD over the past 10 years, with a real acceleration starting in between 2018 and 2019. So this is working quite well right now in our country. This is particularly granular, and it's the last slide I'm going to share for now, which is in our region here. One of the innovations clinically that's enabled the utilization of organs from DCD donors is normothermic regional perfusion. And the standardization in our region of utilizing the OPO in order to implement this protocol, and it's a protocol to perfuse the organs in the donor before the recovery, because one of the barriers in utilizing organs from DCD donors is that there is ischemic injury after the ventilator is removed and the patient is asystolic before death is declared. There is time that goes by, and then the recovery of the organs. And so because there can be damage in that interval, the utilization of organs from DCD historically has been much lower than the utilization of organs from brain dead donors. One of the clinical innovations that is being scaled in our country is normothermic regional perfusion, and this is working well to really improve and increase the utilization of organs from DCD donors. What you're looking at here is our own experience here in the region of taking NRP in-house as an OPO function for abdominal NRP, making sure that it's standardized protocol throughout the region. And I circled in particular the observed to expected utilization rate for liver and for kidney, and highlighting that these are in particular kidneys that might otherwise not be utilized. And so this practice and innovation is really extending the use of these organs. So I'm going to stop the share for now because I think I've probably gone over my time, but I wanted to provide a big picture and a very granular picture of some of the things, practices in clinical innovation that are working quite well in our country to grow organ donation and organ utilization.
This was really great. Thank you for sharing all that. Going to Jean next. What is working well from your point of view?
Well, I'm going to try and share my screen as well here. And I think I'll just leave it here. And hopefully you can see that. First, I want to add my thanks not only to you as the conference organizer, but also to those who have joined us virtually, and to my esteemed colleagues. I think that's where I'm going to start it, what's working well. It is the growing partnership across the entire system to ensure improvement with the organ transplant system, as we've seen in the various graphs and charts that have been shown. There are many things that are working. And this issue has always been extremely important, but I've seen greater visibility and alignment across. I don't know. Are you seeing my actual slide? I want to make sure you see my
we
slide.
were able to see them just until a few seconds ago.
Okay. You got them now?
Yes, yes.
Okay. Just making sure that you've got what I want you to see. So, but yeah, so we, this issue has always been important for this country, and especially for the Department of Health and Human Services. And so what we have seen, though, is more alignment between the federal partners working in this issue. And this has come through a formal commitment to align across federal agencies with the implementation of the HHS Organ Transplant System Affinity Group, or better known as OTAG. And really, I think that we want to note that we've taken a whole of government approach. And this is what's going to be needed to address the system improvement. And specifically, HRSA and CMS have joined forces in the form of OTAG with a goal of strengthening accountability, equity, and performance in the U.S. transplantation system. And OTAG initiatives, we really look at federal policy development. 2 years ago, I heard the question that CMS often gets is, do you all talk? And what this OTAG has done is we forced to make sure that we do talk and that there is alignment as we are developing federal policy. Enhancing system performance is a goal. Establishing consistent waitlist practices. We did a lot of journey mapping, and we heard and we listened, and this was an area that came to us that we needed to work on. And of course, equitable access to transplants. We're working on that. Harmonizing data. That was another area in our listening sessions that frequently came about. CMS used this data. HRSA uses another set. CDC uses another set. Can you all please try and harmonize your data? And we're working on that and making great progress. And then consistent complaint process. There was always the question we've got frequently of, well, what happens? Who do we go to? What happens when we lodge a complaint? And we have a no wrong door policy that we've established and we've worked through within the past few months. And so that the public can be assured if they have something that they want us to take a look at, that if they go to HRSA or to the OPTN or to CMS, it's all going to be going through the right place. We've just launched just this past Tuesday a new HHS website. I can put that in the chart. So there's one place to go to get information. And we also at the same time placed up our new blog that gives progress. It's one thing to have an action plan. We launched that last year, but what are you doing about it? And what progress are you making? And so this blog really is focused upon telling where we are with OPTN modernization, just about to seat a new board there in 2025, consistency in the transplant waiting list, CMMI models, looking at really pulling together and increasing transplantation by incentivizing quality and payment together, and then strengthening the patient safety and quality network that we have. And the last thing I'll say is we're very encouraged by the number of quality improvement and technical assistance efforts that are underway. And CMS is sponsoring several of these through the QIOs, ESRD networks, CMMI learning and diffusion. But there are other areas. OPTN has a learning network, and OPOs are helping each other in quality improvement. And I've had the opportunity to do a number of site visits and see this for myself. So it's all been very, very encouraging.
That was great. Thank you so much. John, what's going
Sure,
well
yeah.
from your point of view?
Yeah, well, thank you, Mario, for the invitation to speak today. I will share a few slides as well, just to give some of my thoughts. I'm a data guy, so I need to have some data to share. So you should see that now. All right. First, a disclosure. My comments are my own today. I do serve as the director of the Scientific Registry of Transplant Recipients, and but my comments are my own today and shouldn't be seen as an official policy of HRSA or HHS. What's working well? I like to just start with some overall trends, and I'm going to focus on some kidney data. And I can just preface this by saying if we look at the other organs, much of what I will show you in kidney holds true for the other organs as well. So I think some of the good news. This is an image from a new tool that the SRTR had launched. My colleague, Dr. Nicholas Wood, created this specifically in response to the NASM report. So thank you, Dennis and Mario, for your work on that, where you suggested that we should have a dashboard of metrics that would allow us to trend things over time in the U.S. transplant system. And so our team worked on that and came up with this tool. We actually had an opportunity to pilot that with the NASM committee before it was launched as well. And so thank you all for your work on that committee. I'll just show you a few examples. This is the trend over the past decade in the number of kidney transplants that are performed relative to the number of people that are dying or being removed from the wait list for being too sick. And the big takeaway here, we're currently at 3.25 as of October 4th, and I'm sorry, October 2nd. And so what you can interpret from that is for each patient who we unfortunately have to remove from the wait list for death or becoming too sick, we are achieving 3.25 transplants. Sorry, Mario, did you have something to say? No, okay. And so the trend, I think, is what I'm really interested in here is the general upward trend. We saw sort of a leveling during the COVID period, and then that has picked up again. So going up is the direction we want to see, more transplants happening relative to people dying. And so if we drill into that a little bit, what's happening to the wait list? We often hear comments in the community that our wait list continues to grow at an outpace. Indeed, the wait list is shrinking and has been on a downward decline over the past decade, and this trend holds for each of the organ types. We've seen that level off in the past few years, but generally over the past 10 years, this is the size of the kidney transplant wait list has been going down. And then when we look at the waitlist registrations, people might say, well, it's going down because we're not listing people as quickly as we were before. And indeed, the opposite is true. So the waitlist registrations are climbing. Obviously, during COVID, we saw a steep drop off in that, but that has picked up again following the pandemic, and this is generally on a rise. So despite increasing registrations on the wait list, we're getting people off the wait list, and we're getting more transplants performed, of course, relative to people that unfortunately are passing away on the list. And what's happening then, the deceased donor transplant rate has been on a steady increase. I think this is a success of our system that we continue to raise this bar over time. We're getting more people transplanted. And likewise, our deceased donor count. This is the trends in what the organ procurement organizations are achieving into the system. Obviously been on a strong increase over this past decade and continues to do so. We can drill into that a bit, and this is a complex slide. I won't go through each of these lines, but the takeaway from this is what I've done here is stratified the quote unquote quality of the deceased donors by a measure that we use called the kidney donor risk index. And what this is showing is that these lines, each color represents about 10% of our deceased donor pool. And what this is showing, if you look at the light blue line at the top, for example, that most of the growth is happening at the riskier and the more clinically complex end of that spectrum. The lowest line on this plot is the best 10% of donors over that decade, which we've seen growth in. It's hard to see on this plot, but certainly not as strong. So all of that growth we're achieving is coming into that more complex spectrum of donors. We're getting more of those complex donors out for transplant. And indeed, the transplant centers are using more of these complex donors. When we drill into this, Alex did a nice job of describing brain dead donation versus donation after circulatory deaths. And this is showing the trends in those. And as she mentioned, the growth we're seeing is outpacing the DCD growth is outpacing the brain dead growth. And it's interesting, you see in the rightmost part of the upper line here, we've started to see a decline over the past year or so in that brain dead pool, which is something that we've taken an interest in our team. And when you look at this by cause of death as reported into the OPTN, I won't highlight each of these lines here, but there was one curious one. Perhaps you saw the report that was published just this past month from the Centers for Disease Control. They have been tracking the opioid epidemic, and that's indicated in the purple line here is all of our drug intoxication deaths as reported into the OPTN. And indeed, we've been seeing that same similar decline in that rightmost part. And so indeed, when you line that up with a report that the CDC recently published, the left here is our deceased donor count from our brain dead population. And then the right is what the CDC just published, looking at recent trends in the opioid epidemic, specifically the drug overdose data that they have available on their site. And you can draw some, this association is not causation, but something that we're interested in tracking. That I think that decline in the donor pool in the most recent year for the brain dead pool seems to track with this here, rather than some other cause that might be, if we're getting less authorizations or less, family authorizations for those events. So something that we're continuing to watch. It's an interesting trend that seems to have been happening over the past year. I thought I would just conclude with some data on growth. This is fairly complex, but what I've done here is just created a dot for each of the 250 or so kidney transplant programs in the country. And they're stratified left to right on this by their volume in 2019. And then what's plotted here on the vertical is their 5-year growth rate. So all of the green dots are true kidney transplant programs that grew over those 5 years, and the red dots are kidney transplant programs that declined in their growth. Dennis will, I'm sure, show you some data on the growth targets that we've established as a community trying to increase transplantation. And when you look at the median growth over that time, there was a 9% increase nationwide was the median growth by transplant. And you can see across the country how that shakes out by state when we look at the states where these programs are located. And one of the concerns that I hear frequently is we'd like to do more transplants, but growing rapidly may put us at risk of outcomes if we're taking more complex donors. But indeed, the opposite is true. To the right are higher growth rate programs, and what we see here is this is associated with better graft failure evaluations by the SRTR, not worse. And the similar trend holds for the other organs as well. So I think that's food for thought to get us started. I think there's a lot of things to celebrate in the growth of our system and how we're performing, and welcome the discussion as we go forward. Thanks, Mario.
Thank you very much, John. And as another data guy, I really appreciate what you have done. Dennis, what is working well from your point of view?
Yeah, thank you, Mario. And I just want to say I'm very privileged and honored to be here today with all of my panelists. And it's not often I get to say in a meeting like this that I agree with everything that's been said, but so far, I'll just say I agree with everything that's been said by each of my colleagues here, beginning first actually with Dr. Cameron, who, pointed out we have a sophisticated, well-organized and well-run, fair and equitable transplantation system that gets better every single year. And I do think that is the bottom line for both the organ donation part of the system and the transplantation part of the system. We have something precious here, and I think we need to care for it as a precious asset. Now, I, like my other colleagues, have some slides that I'd like to share, and I'm going to try to be really quick in sharing these with you, as everyone else has done so well. And I will just kind of quickly begin here with disclosures. I was proud to serve with Mario as a member of the NASEM committee that published our report in February of 2022. I'm currently a volunteer member of the OPTN's Expeditious Task Force. I serve in a couple of roles that are paid with United Therapeutics, Lung Bioengineering Division, and then I also do leadership development activities with others. And I'm not representing any of these groups today. The data that I'll share and the views are solely my own. So 4 key facts to just start with very quickly. And this is kind of a good news, bad news thing. I'm going to kind of be a person that articulates what's working well, as Mario said, but I'm going to kind of begin to take us into the next round about things that need to improve. And first, transplantation is growing nationally. And that's a very, very good thing, but it's growing more slowly than donation. And that's not so good. That's a challenge and a problem. And I'm going to drill into that a little bit deeper. That's when you look at the averages. However, when you look at outliers, we see that there are transplant programs that have grown dramatically and successfully with good outcomes, 100%, 200%, 300%, and more growth over the course of the last 5 years. And the programs that are growing, and you heard John just share a quick slide about that, that they're doing this growth within all the constraints of the current system, right? They're not getting a better deal from the OPTN or less regulation or oversight from HRSA or more money from CMS. The programs that are achieving 200, 300% or more growth over the last 5 years are doing it within the constraints of the current system. And as John was saying earlier, they're doing so with good outcomes, which is really spectacular. So that's kind of bottom line first in terms of this issue of organ use. And I'm going to drill a little bit deeper into this. So if we look at donation nationally, over the course of the last 5 years, 2018 through 2023, donors are up 8.8% annually. And you've already seen some of that data from Alex. When you turn to the transplant side, though, kidney transplants are lagging. 43% growth over the last 5 years, or 7.4% annually. And it's actually this problem, if you will, of non-use of organs is actually worse for the other organs than it is for kidneys. You see liver up 27% over the last 5 years, hearts up 33% over the last 5 years, lung transplants up 19.6%. And every single year that transplant lags donation, we dig a deeper hole, and the problem of non-use grows greater. So this is a pressing problem that deserves significant attention. Now, I mentioned earlier that this isn't the case. I just shared with you national averages. Now let's look at some of the outliers. Let's look at some of the programs that are growing. And what you see here are the 10 kidney programs in the United States that grew the most over the last 5 years in terms of the sheer number of increased, or the volume of increased transplants. So at the top of the list, you see that, for instance, Hackensack University Medical Center went from 66 kidneys in 2018 to 272 in 2023, 312% growth. If you go to the bottom of the list of 10 here, University of Toledo, they went from 68 kidneys in 2018 to 195 in 2023, or 187% growth. And you see all the other programs in between here, right, in terms of ranked by sheer volume of increase. Now, they're not alone. There's another 20 kidney programs that, if we went further down the list, we'd see this same pattern of dramatic growth. And as John was saying with one of his slides, these programs that grow, they're bold, but they're not careless. Like, they are getting good graft survivals, good 1-year graft survivals. This is SRTR risk-adjusted data for each of those top 10 kidney programs. And in this case, more bars is better. So 5 bars is the best, 1 bar is least. And you can see that these very dramatically growing programs are doing quite well in terms of their risk-adjusted 1-year graft survivals, and also on 2 other measures that matter a lot to patients: getting a kidney faster and survival on the wait list. Now, this pattern that we have with kidneys cuts across all the other major organ types. I'm showing you here the top 10 programs in terms of growth for heart transplant in the United States, beginning with Duke University Hospital, 77 heart transplants in 2018, up to 155 in 2023. And again, you see this pattern of dramatic growth. 307%, 200%, 1,043%. Like, these are phenomenal numbers. And again, they are doing this with good graft survivals and good patient outcomes across these organ types. Now, I have a slide. I didn't include it here. I have it in an appendix. I can show it if we need to later. But Ken Kaiser, the chairman of the NASEM committee, who transformed the Veterans Health Administration a number of years ago, had us compare the hazard ratios, that is 1-year graft survival hazard ratios, for the top 10 growing programs in each organ type, and compare it with the hazard ratios for the programs that changed the least in the last 5 years. and the programs that shrunk the most in the last 5 years. And in every single case, for every single organ type, the hazard ratios are better for the growing programs than they are for the maintaining programs and the shrinking programs. So again, bold is not careless. Like, we can achieve phenomenal outcomes. Now, this is the last slide, Mario, and it kind of begins to get into some of the more somewhat negative things, or things that need improvement. We've got a great system, but as Dr. Cameron said right at the beginning, it can be a whole lot better. This is a slide that was created by our NASM committee and used extensively, particularly by our chairman, which is why it's got the NASM logo on it, in describing some of the things that we identified as part of the NASM report. And I'm not going to go through the whole slide, but I want to just call your attention to a couple things. There are these common perceptions that you see on the left, then the reality on the right. And a lot of the common perceptions don't square with reality. So the first one is that people who die waiting for an organ, they were just too far down the list, so they didn't get any offers. And that's not true. People who die waiting for organ offers, for transplants, their transplant centers in many cases got lots of offers for them. But they were never transplanted. The offers were rejected. So they weren't too far down the list. It was something else that was limiting what happened there. Maybe skipping down to the third row, that scarcity of organs is the principal limiting factor in getting a transplant. And while there aren't enough organs to go around, many of the organs that are available, that are procured or available for procurement, are not being used. And you saw that in the second slide I presented, which really puts a fine point on that third line in the chart. And then I'll just skip down to the very end here real quickly and say, a common perception is that patients have to wait a long time in order to get a transplant, and or to get an offer for a transplant. So the reality is that offers begin to come to patients very soon after waitlisting. And in some of these high growth transplant programs that are accepting these offers at much higher rates, those patients are getting transplanted much more quickly. I'll give one quick example. Hackensack University Medical Center, remember, they were the kidney program that grew the most over the last 5 years. The average length of time, the median length of time that patients wait for a kidney at Hackensack is between 110 and 120 days before they get a transplant. That's possible for far more patients. We need to do a better job of accepting and using the organs that have been donated and are available for procurement across the country. This isn't a regional thing. This is true across the country. I'll stop there. Mario, back to you.
Thank you, Dennis. So thanks so much. Like you said, it would be really great if we could just stop here and just just after hearing about what you see as the successes of the current system, but as it has also been hinted at and mentioned, there are areas of concern. Dennis, did you want to? I know you wanted to, and thank you for being a bridge between, again, the first round, what's working well, and the second round, what isn't working well. Was there anything that you wanted to add to what isn't working well, or have you covered that part too? Just wanted to be sure.
Thank you, Mario. I would say that a key area that deserves attention that's not working well is utilization of available organs. Donor families have generously made these organs available, and OPOs are recovering many kidneys that are not being used. I think you'll see some data from Alex, but we're projecting that this year, almost 10,000 kidneys that will be procured will not be used. They'll be discarded. And it's not because they're poor quality. Some of those kidneys should be discarded, and some of those kidneys are of too poor quality to be used, but thousands of those kidneys could and should be used. So I'm putting a real fine point, Mario, on the need to better utilize the available organs and to stop wasting not just kidneys, but hearts, lungs, and livers as a pressing priority. I think the second one I would say, and I'll maybe come back to this more near the end, is we've got serious issues with equity, particularly equity in gaining access to the transplant wait list. And that's something that we need to go to work on. And because CMF pays for such a high proportion of the kidney transplants, I think that's an area where we could make rapid progress in addressing some of the inequities in transplant listing and transplant and access to a life-saving and life-enhancing kidney.
Great. Yeah, thanks again, Dennis. So I'm looking at the time. So let me suggest that we combine our second and third rounds. So second was, what isn't working, and third was, okay, what can we do? What should we do? Or what is being done? So let's combine those two rounds together in the next round of contributions. Dr. Cameron, Andrew, would you like to share your thoughts?
Sure. Again, so now is the tough part. Now is what we need to do better. I'm gonna say, at the risk of being unpopular, it's tough. It's choppy waters to some extent to criticize the system, because I think we are predicated on the public's trust in terms of donation. And I think if we are inflammatory in our critique of the system, we run the risk of fracturing public trust in a way that will do us a disservice. So I'll put that out there. So for example, transplant centers, as perhaps we just saw, are very, very highly regulated and scrutinized by the government. And if you went online right now with a couple clicks, you could get the 1-year survival rate for every single center, for every single organ in the United States, as was just presented. That we're doing a great job on that. We are here today perhaps to talk about organ donation and organ recovery and the system of OPOs in the United States. And some have suggested that we ought to do an equally good job of regulating OPOs and of understanding metrics of performance. So we're here to talk about donation, and a lot of the slides that were just put up were referencing transplant center outcomes. They weren't referencing OPO performance, the topic of today. And so I think we could look at the process from start to finish. Again, I believe in it. I think the public believes in it. I think we have to be really cautious. So it's getting into very nuanced territory, this notion that good organs aren't used. And I would hesitate to have the implication that transplant professionals are throwing away and wasting good organs that could be used to save patients' lives. That would run counter to my 20 years of experience in organ transplantation. There are often complicated, valid reasons why a particular organ doesn't get used. And though we should spend a lot of our focus on the gift of life and the miracle of a successful transplant, it is important to avoid unsuccessful transplants as well. And again, that's a matter of teamwork and communication and trust between a patient and their physician as to how much risk we're going to accrue as we try to get everybody transplanted. And as we work through those complicated issues, we need to maintain the public's trust and try to help them understand how we can all work together towards increased organ utilization. And we probably have to be very careful about steering away from a notion that there are malignant forces out there that work against transplantation.
Thank you. The issue of trust, I agree, is extremely important. It's, takes a long time to build trust, but sometimes a single mistake is sufficient to destroy it. So it's really important that we keep trust in the system. Alex?
Yeah, I think, what Dr. Cameron just explained very eloquently is why OPOs should not be held accountable to a transplant rate. Because in fact, in the end of the day, it's the transplant physician who should be making that medical judgment as to whether an organ is appropriate for his or her patient in a particular circumstance. And so one of the primary challenges I wanted to present today is the CMS metric for OPOs, which holds an OPO accountable for a transplant rate and, in fact, can decertify an OPO solely on the basis of a transplant rate. So hold on, I'm going to share my screen. So thank you, Andy, for setting me up so well. Actually, before I do that, I do have the data. I think, Dennis, this is what you were referring to that I was going to show, which is just over time. This is kidney specific, OPO recovered kidneys that were unused, kind of going up over time in rather large numbers with a projection from 2024. Now, this projection was from a couple of months ago, so it may even be a little bit higher now. And the number of deaths on the kidney wait list going down, which is great, but we've got this widening gap. So I really resist the urge to say that we have a scarcity of kidneys. We don't. We have a surplus of kidneys. Now, to Dr. Cameron's point, whether or not they're appropriate kidneys for transplant, I'm going to leave that up to the surgeons. But we do know that what OPOs are doing is approaching more families, broadening the pool of potential suitable organ donors, checking and getting provisional yeses before we're going to the OR, and then offering these kidneys out. Ultimately, though, a lot of them are declined after recovery, and this results in zero organ donors. Zero organs transplanted from these donors. And you can see this number going up. By the way, the percent also goes up. Percent of donors where there's zero organs transplanted going up. And just to give you some numbers before I turn to the CMS metric, this is my own OPO, New England Donor Services. This is year-to-date data. The number of kidneys accepted for transplant so far year-to-date, 673. Kidneys not accepted, 283. Of that 283, the average number of offers per unused kidney that our OPO has made trying to place that kidney is over 8,000. And then the total number of offers made on the 283 kidneys is 2.3 million. 2.3 million, that should be eye-popping. So I think, the challenge is we can do better from a system efficiency perspective to try and place these kidneys. And if these kidneys aren't ones that should be used for transplant, what are they doing in our denominator from a performance metric perspective? And just so you know, at least in the past 2 months, looking at this data and actually year to date, the number of these the percent of these 283 kidneys where we had a provisional yes before we went to the OR ranges from about 77% to 85% of these. We had a provisional yes before we went to the OR. So reasonable expectation that these would be placed. Okay, so this brings me to the OPO metric. I'm going to have to be super fast. I don't know if everyone on this call understands what the metric is, but there's 2 rates, and an OPO is going to be placed in a tier based on the higher of the 2 rates. And one, as I mentioned, is a transplant rate. And the threshold's at the top 25th percentile, which is really unprecedented in a CMS metric. But we've already looked at this growth chart from a 10-year perspective. I'm cutting it at a 3-year perspective because that's the data we have on tier placement. The threshold is a moving goalpost. So this is actual numbers of donors has increased. The rate, according to CMS's calculation, has also increased. And the tier 1 threshold has increased. So we have a moving goalpost on the donation rate. We have a moving goalpost on the transplant rate. And this means despite increasing numbers, despite increasing rates, we have a decrease in the number of OPOs and percent that have been placed in tier 1. And this results in negative media and statements like more OPOs are failing than ever, when in fact, we have really an illogical situation in the regulation. So I'm going to stop sharing there and just say that we have opportunity to do better in the regulation, to really align it with the realities of the system, to ensure that it incorporates the point that Dr. Cameron made, that transplant decision is ultimately rests with the surgeon. And that as we push to align the better utilization of organs, we really need to have that regulatory metric also aligned. So accountability for organ utilization is appropriately at the system level. And I think with that, I'm going to pass the baton because I know we're very tight on time.
Thank you, Alex. Yes, we are a little bit, but this tells me that perhaps we should plan on doing a second webinar because clearly the conversation could continue for at least another hour. But for now, Jean, please.
Thank you. And I'll start by, there continue to be a number of challenges. Was initially challenges, but then also solutions. And I would agree that increasing the transplant rate and addressing issues of non-use is number one. And we do recognize the responsibilities of federal agency, the need to ensure that incentives, oversight, payment, measurement of the entire system. So not to address just one portion of the system as the organ procurement organizations without addressing transplant centers, clinicians, all that are involved in the system. Everyone has to accept responsibility for an improved system. And therefore at CMS, we take a approach where we're using all available levers, one of which is regulation. And we've seen the impact that the rates continue to improve. And we did take a lot of public comment on those metrics as they were developed and continue to look at them as we go about and see the data. We've also proposed the CMS innovation model. And this is a 6-year pilot program really aimed at increasing kidney transplant access. And it is focused on the kidney transplant hospital. So as to use more available kidneys and facilitate more transplants from living donors. If finalized, this program is expected to begin almost immediately in 2025, so that we are looking at the organ procurement organizations, we're looking at the transplant centers, and we have other things underway that would continue to look at the system overall. We hear and we know that there continue to be transportation issues. We're working very closely with HRSA and FAA on those issues so that we can, once these organs are procured, that they can safely get to where they need to get to so that they can be transplanted. We are working on process improvement efforts to ensure efficient avenues for organ procurement organizations that are seeking mergers, changes of ownership, and other means in which a DSA are combined or reassigned so that this can be an efficient process. We continue to work on the accuracy. This is a challenge, accuracy and transparency of data. We need accurate data to determine true improvement and for enforcement purposes. And I know and have seen that inaccuracy leads to mistrust. And so on August 29th, after consultation with HRSA and Oregon Procurement and the OPTN, CMS released a memorandum providing OPOs with updated pancreatic codes to differentiate between pancreatic use for islet cell transportation or research and pancreatic use for non-islet cell research. And so this is intended to help the OPOs distinguish their data and use for what's being used for bona fide research, and so that we can then mine that data once we get it. We are still working on, and we know the issues related to transparency with the wait list. I see one of the questions in the Q&A is around this. HRSA did issue a information collection intention in the Federal Register. Those comments are due by January 3rd, which will provide more information from the point of referral so that we can have more information throughout the entire system. I know that there are questions around recertification process, and we will address those through rulemaking. And I'll say that while there's notable improvement, we continue to receive complaints that are coming into our office that we must investigate. So we want to be on the front end of those issues. We hear many things from the press, which leads to some of the mistrust. So if we could get on the front end of that and be in prevention mode and not in reaction mode, I think that will help with some of the public perception as well. And I could probably go on and on. I know we are at a lack of time. So the last thing I'll mention is there's no reentry pathway for OPOs that are subject to decertification or opportunities for new entrants. And their administration has included legislative proposals to remove restrictions on certification of new entities and increase the flexibility that we would have as we work to improve the regulations that currently exist. So I'll stop there.
Thank you very much, Jean. This is a really rich discussion. John, please.
Yeah, I mean, so many good points have been made. I'll just highlight one piece that intrigues me about some of the things. I think public perception is a strong concern here, and we hear lots of where the failings are, and don't really. I think we run the danger, as Dr. Cameron nicely pointed out, to not really drill in and understand what the underlying issues are, and this is the trend in the kidney non-use rate, previously referred to as discard rate. So kidneys that are actually offered out by the OPOs for transplant, but then not transplanted. And you can see the steady rise, and it's concerning. Certainly, it's up to about 29% now. But I think when we dig further and take into context, what I'm going to do is just stratify this plot out real time for you based on those deciles of kidney donor risk. And again, you saw my plot before showing that most of the growth in our system is on the more complex side. And each one of these lines represents those same 10 categories of donors with the highest quality donors at the bottom. And you can see that indeed on those, we're not we are using those that are being offered at a similar rate than we were 10 years ago. That's the low end of this down here. And indeed, in the high end, it kind of flattens out as well. And so in other words, when you adjust for or you take into account the increasing donor complexity of the donors that are being offered out and successfully procured by these OPOs, that does explain a large amount of that increase. And so we have to be aware of the drivers of that increase. And Alex nicely showed the data from New England. And I can just share, I've got some numbers in front of me here. Nationally, she showed the data for New England. Nationally, in 2023, we recorded 8,570 kidneys that were not used for transplant, although they were procured for transplant. And the offers that went out for those kidneys was north of 26 million offers. And so I think it's important to understand that these have been seen by lots of transplant programs and deemed to not be suitable for transplantation. So I think this is something that we have to continue to wrestle with as we think about system performance. I caution against certainly we need to measure and understand at the transplant side and the OPO side where the opportunities for improvement are, but it's difficult to really sort of focus too heavily on one side of that equation without understanding the full picture. So I'll stop my comments there. Thank you.
Thank you so much. And I'm looking at the clock. I think I would like to thank Jean for. We have several questions from members of the audience. I'd like to thank Jean for addressing one of them. I think we have time for one more. This is for Dr. Cameron. I'm going to read it. Dr. Cameron, thank you for your leadership at Hopkins. Yes, and I also would like to add my thanks to you for that. The question is, what are the top 3 opportunities you would list on the clinical side to increase organ recovery? Staffing, for example, technology, artificial intelligence, and so on.
Sure. Great questions, great ideas, and indicative of the fact that we need to be working everywhere all the time. A couple off the top of my head. I think there are great opportunities for living donation. I think we really underachieve in the United States. So we talked about the organ transplant wait list. It's 100,000 Americans, roughly 80,000 are waiting for a kidney. We all have 2, and donating is a very safe procedure. So could we be doing more on living donation? Living donation is actually going down in the United States. Talk about technology. There's some really exciting new work being done on how we store organs between when they're taken out and when they're transplanted. Normally, it goes into a little cooler and is kept cold. That's been working well for 40, 50 years. There's another way to do it. You could put the organ on a pump and pump warm oxygenated blood through the organ while it gets to the recipient. That's really valuable because it allows you to see how well that organ will perform when transplanted. It helps us to understand which organs that we might have thrown away incorrectly are usable, and it also helps us decide which organs we shouldn't use. And that helps our recipients in both directions. So I think there is exciting technology, that's going to help us make these decisions. AI is a really interesting idea. I hear concern on this call that, maybe overworked transplant surgeons aren't always being as aggressive as they should be. Well, maybe so. And maybe there are algorithms that could help assist us in our decision making that would take some of the subjectivity out of our decision making. And I'm really interested in that topic. So again, we got to all work together on this. I know everybody, on this call and listening is working for the needy recipients on the wait list. Where we make improvements, is going to be a team effort. Maintaining the goodness of the system we have now while we improve its shortcomings, maintaining the public trust on that journey, I think is paramount. I want to thank everybody on this call for the work they do, in that direction.
What a great way to end this webinar. But before closing, I'd like to give the opportunity to our panelists to add. Is there any last words or additional comments that you would like to share before we end our webinar?
Yeah, I'd love to. Thank you, Mario. Just very quickly, I'll say that the OPTN Board of Directors set a bold goal in December of 2023 to achieve 60,000 deceased donor transplants by the end of 2026. This was a goal that was based on data. If our system were to perform at the levels of growth that have already been achieved by the upper 20% of transplant programs nationally, we would hit that target. And I've been part of a series of 9 meetings. We had our last one, working session, 9 working sessions across the country with transplant centers where transplant surgeons, transplant administrators, and hospital C-suite leaders from high growth programs are engaging directly with other C-suite leaders and transplant programs and surgeons to share the best practices around growth. And it's very uplifting. Nearly 100 transplant centers have now set ambitious growth goals that are consistent with hitting that 60,000 target. It's very encouraging and exciting because it's the community helping the community to get better. And it's just extraordinary work. So I have tremendous hope around this.
Very encouraging indeed. So a colleague just sent me a question by text, noting that we didn't talk much about living organ donors, particularly kidney donors, and asking whether I or the panelists think that one reason for the organ shortage is the lack of financial compensation for living kidney donors. I think this is an important question that deserves its own webinar, so we're not going to go into that. Thanks again to our audience, and again, very much a big thank you to our panelists for a really informative and rich conversation. Even as someone who knows a fair amount about the system, I learned a lot. Many insights were offered, not only ideas for policy improvements, but also from my point of view, also for future research. So once again, thanks for an incredibly informative conversation.
Thank you. Thank you very much.